Hello, Supervisor Mitchell is joined.
I am testing for Dr. Ferrer.
But I sent it over to Christina. I don't know if that's.
Oh my God. Okay. How are you, Supervisor? Nice to see you. I think you might be muted.
I said it depends. How are you?
Oh, I'm fine. I'm
Okay.
fine.
You're good.
I- I'm trying to figure out, are we live?
I don't know.
Yeah. I was looking for our team, but I don't see them on, so. Erica? Kim?
I'm here. My apologies, Dr. Ferrer, getting this slides and talking points loaded.
Oh, that's fine. I know it's last minute. I just wanted to find out if our mics are live.
They are. You are currently
Okay.
on with the press.
Okay, great. So we'll just wait for you to load up.
All right, Dr. Ferrer, I'm loaded, but I figured we'd go ahead and wait until 2 p.m. to start.
Yeah, that sounds perfect.
All right. We have reached 2 o'clock. Good afternoon, everyone. Thank you for joining the Los Angeles County Department of Public Health today, January 20th, for a media briefing. Today, we have Director of Public Health, Dr. Barbara Ferrer, and Los Angeles Board of Supervisors Chair, Supervisor Holly J. Mitchell, presenting. Both Supervisor Mitchell and Dr. Ferrer will take your questions. To ask them a question, please use the hand icon, or you may chat me, the host, Supervisor Mitchell, when you're ready.
Thank you very much. And as always, thank you for including me in today's briefing. You know, our county priority is to do all
Supervisor Mitchell, we're having a hard time hearing you.
Can you hear me now?
It's very quiet. Dr. Ferrer, I'm not sure if you're able to hear Supervisor Mitchell better than myself.
You're faint.
Sorry.
Now that's worse.
Is this any better?
Yes.
That's better?
Yes, much better.
Oh,
A little bit better, yes.
Okay. It's rare that I'm told I can't be heard, truly. So I will make sure that I speak loudly. So thank you again for allowing me to participate. And I just want to start by saying that it really is our priority as a Board of Supervisors to do all that we can to keep schools and businesses open safely and protect those most at risk of getting sick. You know, our kids, older adults, our unhoused population, those with pre-existing conditions. And so our board is committed to continue to ask hard questions about health equity to get the resources to those who need it the most. I was proud just yesterday, the New York Times published an article on the vaccine clinic that we've partnered with the Department of Public Health with at Ted Watkins Park in my district. The Department of Public Health staff have invested in relationship building with giveaways. We're doing whatever we can to get people to come. Tacos, balloons, whatever it takes. Again, doing the hard work to engage community in a meaningful way, to connect with government to get this resource they need. So I want to uplift this often unseen but necessary work to get people vaccinated. My staff have been visiting these sites and going through the pre-registration process because we really want to make sure that technology isn't a barrier to service. And so we're thrilled that so many of the clinics are taking walk-ups. I'm sure Dr. Ferrer will share the website to find a testing location, but I think it's really important that our media partners elevate those websites. Also, to make sure people feel confident that the testing site they go to is kind of a legitimate one. I hear from constituents almost on a daily basis who are concerned about this test site they've gone to. So I know that there are websites where you can find out where the county is engaging in testing, as well as just verify that the test site is a legitimate one. Just this week, the second district, we hosted a call with over 70 faith leaders who were eager to learn about testing sites and are willing to step up and host testing sites in their parking lots. And so that just was further evidence to me that the greater community wants to help each other in finding access to critical testing, as well as the ongoing need for vaccination. Again, I remain concerned. I represent the second supervisorial district that has one of the poorest vaccination rates of the entire county. So continuing to push the message about the importance of vaccine, as well as testing is critical. I also represent SoFi Stadium, and so I'd like to thank Dr. Ferrer. We've been in meetings at the staff level this week to hear and learn about all the work that you have done and helped lead with your NFL partners, with SoFi leadership, to make sure that this year's Super Bowl will be as safe as it possibly can for the 75,000 who will likely attend. So with that, Dr. Ferrer, thank you very much, and I look forward to hearing your update as well.
Thank you so much, Supervisor Mitchell, and good afternoon, everyone. I want to particularly thank the supervisor for all she's doing for the residents across the whole county and her leadership during these challenging times. I really appreciate the opportunity to work for her and her staff, and I'm pleased that the leadership of this board has been with us, really from day one. So I want to just acknowledge, how much we benefit in LA County from having a board that has been really committed for over 2 years now to doing right by all the residents in the county, so that we can best get through what are, really very, very challenging times. This afternoon, I'll first provide an update on our current cases, hospitalizations, and deaths, followed by an update on our most recent vaccination data. I want to talk a little bit about managing surge at our LA County schools, and we'll end with a review of testing resources, steps that people should be taking after they test positive, and how vaccines can make a difference. So I'll take the first slide. As you can see on this slide, while case numbers and test positivity are extraordinarily high, there are small decreases from last week. The average daily new case rate is now at about 33,000 cases a day. Test positivity decreased slightly this past week to approximately 17%, meaning that nearly 1 in 6 people getting tested is infected with COVID. The 7-day average daily case rate also dropped a bit to about 350 new cases per 100,000 residents. And while these small decreases may indicate that we're no longer seeing exponential growth in transmission, we're still experiencing the highest rate of spread for this entire pandemic. And with so many cases, our hospitalization numbers remain elevated, with 4,814 people currently hospitalized. This is the highest number of daily hospitalizations for COVID since last winter's surge. And tragically, we've also seen that as we've experienced in the past, where a few weeks after a surge in cases, deaths tragically also increased. Today, I'm extraordinarily sad to actually report 102 new deaths from COVID-19. This is the highest this is the highest number of daily deaths we reported since March 10th of last year. The number of new deaths has doubled in just the past week, and 90% of the deaths reported today are among individuals who became ill with COVID after December 24th, indicating the high likelihood of an infection with the Omicron variant. To everyone devastated by the loss of someone they love from COVID, please know that I join with many others in sending my thoughts and prayers for healing and peace. Test positivity also remains very high, as I noted, at 17%. And again, as we noted earlier, the daily average case rates, while elevated, you can see from here that they have dropped pretty significantly since Friday of last week. We'll take the next slide. This slide really, it's our usual slide that shows new cases, hospitalizations, and deaths between July 1st of last year through today. The rise in cases, which you can see represented by the green line at the top, is nearly a straight vertical line until just recently, where you can see a small decrease. This recently observed downward dip for the 7-day daily average new cases, it may signal the beginning of a decline, but I also want to note that it reflects reporting delays of cases from the long holiday weekend. And as you can see on the case trend line, there's been about 3,000% increase in cases since the beginning of December, where we went from about 1,000 new daily cases to now approximately 36,000. Similarly, hospital admissions, that's the orange line, increased nearly 1,000% since the start of December, from less than 60 new daily admissions to more than 600 daily new admissions. With the more recent uptick in deaths over this last week, you're now unfortunately seeing the blue line start to rise as well. We'll take the next slide. If you look more closely at hospitalizations, as we note on this slide, that rapid increase in COVID hospitalizations over the past weeks, which is the orange line, is now also correlated with an increase in daily hospitalization census, and that's the red line at the top. With daily census now over 15,000 hospitalized patients, hospitals are pretty close to reaching the total census that they experienced during the surge of about 16,500 patients. As we look at hospitalizations, it's also important to note that our current model estimates that the percentage of hospitalizations due to COVID illness is about 50% of all of the COVID positive patients. This means that 50% of those people currently hospitalized as COVID positive patients are actually in the hospital for a non-COVID related illness or seeking a non-COVID related treatment. Nonetheless, as I've noted before, regardless of their reason for hospitalization, all COVID positive patients require resource intensive precautions that place additional strain on our healthcare system, particularly in the setting of the current staff shortages. Next slide. COVID patients, as you can see on this slide, account for about 30% of those in the ICU, which this is also an increase from last week where it was about 25% of ICU patients. Between the increases in deaths and hospitalizations, there should be no place for complacency. While Omicron is not causing the same proportion of severe illness as last winter, and you can see that on all of our slides, it is substantially increasing cases of severe illness. And for a growing number of LA County individuals, Omicron has now become a critical matter of life and death. Next slide. As always, we do track the latest data on sequenced variants here in LA County. The red bar represents Omicron, and the blue color on the bars represents Delta. As you can see, similar to patterns all across the country, Omicron accounts for nearly all sequence specimens at 99% for the week that ended January 8th. Next slide. As Omicron has rapidly become dominant, case numbers have risen. And as you can see here, they've risen over the past few weeks across every community in LA County. The darkest green color on each map represents the 20% of communities with the highest case rates of COVID-19 for those particular 2-week periods. The maps are time sequenced from early December through early January. At the beginning of December and early on in the spread of Omicron, while we still had a fair amount of Delta circulating, those most likely to become infected often were travelers, those attending entertainment venues, and those intermingling in places where many were close together while unmasked. Some of the recent shifts associated with widespread community transmission likely reflect the fact that we're now seeing increased transmission among those whose jobs are putting them in close contact with others and who often live in crowded housing. And you can see that with now, sort of our highest case rates being in parts of South and South Central LA, Also, we see them for East LA and parts of our Valley communities. Next slide. Throughout the pandemic, we've also witnessed our Black and Latinx residents experiencing the worst health outcomes from COVID. As we look during our most recent surge, unfortunately, we're starting to see a very similar pattern. This graph shows case rates by race and ethnicity from June of 2020 through January 8th of this year. While it's clear that all races and ethnicities are experiencing significant increases in the case rates due to Omicron, with the near vertical lines for every single group in the most recent time period on the right side of this graph, you do observe that the highest case rates are in the Latinx community, represented by the yellow line, with approximately 3,600 cases per 100,000 individuals. This is a 1,900% increase compared to just 1 month earlier. African American and Black residents, represented by the green line, have the second highest case rate, with nearly 2,700 cases per 100,000 residents, and that's a 1,400% increase in 1 month. The Asian population, represented by the blue line, has actually seen the steepest percent increase at 2,400%, with a case rate of 2,300 cases per 100,000, and that's followed by white residents, represented by the purple line, with an 1,100% increase and 2,100 cases per 100,000. Overall, as we've unfortunately seen during previous surges, our Latinx and Black residents continue to disproportionately experience the high burden of cases as observed currently during the Omicron surge. Next slide. When we look at hospitalization rates by race and ethnicity, we do see a similar pattern. All groups have experienced significant increases. However, as we've seen during all of the past surges, Black and Latinx communities are hospitalized at disproportionately higher rates than white and Asian residents. For the 2-week period up through January 8th, the hospitalization rate for Black residents was 47 hospitalizations per 100,000 people. For Latinx residents, it was 29 hospitalizations per 100,000 people. For white residents, it was 17 hospitalizations per 100,000 people. And for Asians, it was 8 hospitalizations per 100,000 people. The gap between Black residents and Asian residents is nearly 6-fold. Next slide. When comparing the death rates across race and ethnicity, it does look like the lines may be running closely together on the right side. However, if we were able to magnify that data, you would see that gaps are already opening up here as well. The rates of death currently for Black residents is about 3.5 deaths per 100,000 residents. For Latinx residents, the rate is slightly over 3 deaths per 100,000 residents. This is compared to lower rates of death for white residents at 2.5 deaths per 100,000 people and Asian residents at 1 death per 100,000 residents. Given that deaths typically lag hospitalizations by a few weeks, we may unfortunately see increases across all race and ethnicity groups and also further widening of these gaps in the weeks to come. Next slide. When we do examine hospitalization rates for a 2-week period through January 8th by both race and ethnicity and vaccination status, it's clear that across all race and ethnicity groups, the unvaccinated are hospitalized at substantially higher rates when compared to those vaccinated. The vaccine is clearly continuing to provide that substantial protection to everyone who's vaccinated. Nonetheless, I do want to note that hospitalization rates for Black and Latinx populations are substantially higher compared to non-Hispanic whites and Asians across vaccination status. For example, unvaccinated Latinx individuals have 3 times higher rate of hospitalization when compared to unvaccinated Asian individuals. And vaccinated Latinx individuals also have a 3 times higher rate of hospitalizations when compared to vaccinated Asian individuals. These differences, which we also see among African American and Black residents, are likely to reflect higher rates of underlying health conditions among Black and Brown residents due to inadequate access to health-affirming resources. Next slide. Vaccinations, as we just saw, provide powerful protection against the very worst outcomes from COVID. That was true last January when we were first able to get vaccinated, and it remains true today. Over this past year, more than 77% of residents 12 and older became fully vaccinated, along with nearly 90% of residents 65 and older. And this represents real progress. However, the number of children ages 5 to 11 with at least one dose stands at only 29%. This is far below all other eligible groups across LA County, and it creates significant vulnerability for increased spread, not just among children, but among all of us. While we continue to be grateful for the nearly 3 million LA County residents that received their booster doses, there are an additional 3 million more residents ages 12 and older who are now booster eligible and didn't yet receive their additional dose. Since the data continues to show that our immune systems need to be boosted, we urge those eligible to take the time to receive their additional layer of protection. Next slide. We also continue to track our progress administering vaccines on this chart that we share every week. First doses administered each week are represented in blue, second doses are in yellow, and additional or booster doses are in orange. Last week, we administered approximately 260,000 doses, and this sadly is a decrease from the prior week by approximately 50,000 doses. Some of this may reflect the holiday weekend. The majority of these doses, 180,000, were for boosters, 50,000 were first doses, and 34,000 were second doses. We'll take the next slide. And unfortunately, a year into vaccination campaigns and making sure that everyone has easy access to free vaccines, there are still enormous coverage gaps by age groups and race and ethnicity, as you can see on this table. Most troubling are the overall coverage numbers for children ages 5 to 11. And I've noted that earlier in the fact that we're only at 29% of children in this age group receiving even one dose. But it's notable to, on this table, to see that only 1 in 6 Black and Latinx children ages 5 to 11 are vaccinated. With millions of children across the county now in this age group having been vaccinated, and with the high rates of cases among children with Omicron, we are hopeful that parents will feel more confident in the need for vaccinations and the effectiveness and safety of these child vaccines. And while some gaps among teens and adults have closed slightly, you can see we still need to continue every effort to ensure that those not yet vaccinated have easy access to both good information and the vaccines. Next slide. Efforts do continue by administrators, staff, parents, and students to ensure safety at our schools. One important strategy for minimizing exposures, especially during surge, is testing. This slide shows school testing volume represented by the blue bars and test positivity represented by the purple trend lines since last August. Of note, there's a significant drop in testing volume in late November and in December, and that was from the holiday breaks. Most recently, nearly 100,000 tests were administered to students and staff at K-12 schools between January 10th and 14th of this year. Among the tests that were administered, 11% were positive, and this, I want to note, is a decrease from the prior week where we noted a 15% positivity rate. We're hopeful that test positivity will continue to decline as asymptomatic infected students and staff are identified early and therefore much less likely to expose many others at their schools. Next slide. We also can look at the TK through grade 12 staff and student cases from August 20th, 21 through January 16th of this year. And we do note that most recently in this last period of this last week, we identified 37,005 student cases. That's that blue line. And that's a pretty big increase, as you can see, from prior weeks. Among staff, that's the purple line, there were 4,882 staff cases that were identified last week. And I want to note that this graph includes only those cases that were on campus within 14 days of their positive test. These are large numbers because, as you can see, there's both been a lot of testing and we have a lot of community transmission. Most of the cases at schools represent community-based transmission. There have been very few school outbreaks identified thus far, and we can go on to the next slide so folks can see that. As of January 18th, we're responding to about 24 active school outbreaks with 3 new outbreak investigations that were open this past week. And as a reminder, when transmission in schools is characterized as an outbreak, when there are 3 or more cases linked to a known exposure that happened at school or at a school activity. Of the 3 new outbreaks that were open this week, 2 were at elementary schools and 1 is at a high school. But given the continued high rates of community transmission and the significant rise, as you've all seen, in cases among students, we do anticipate that during surge, there are likely to be more outbreaks in the weeks to come at our schools. This would be similar to the dramatic increases in outbreaks that we're seeing across all of our other workplace sectors. As always, limiting spread during outbreaks relies on a variety of strategies. We can go on to the next slide to sort of look at additional measures at our schools. To ensure safety at our schools, I want to note that there are over 140 school-based vaccine clinics that are scheduled just this week. And we have nearly 500 school-based vaccine clinics scheduled for the month of February. These school clinics offer pediatric doses for those 5 to 11-year-olds, as well as boosters for any eligible students 12 years and older, as well as vaccines for students and adults that are 12 and older. Schools are also working with public health and the LA County Office of Education to increase testing capacity to best manage potential school exposures while supporting in-person learning for as many students as possible. 1.4 million tests were already delivered to schools from the state through a partnership that we have with all the districts and with the LA County Office of Education. And we're continuing to augment testing support right now to schools, staff, and students. I do want to note that all infected students, everybody who tests positive, and staff are required to isolate at home away from others for a minimum of 5 days. Asymptomatic students and staff that test negative on day 5 of their isolation period can return to school on or after day 6 of their isolation period. But returning students and staff must remain asymptomatic, and they always have to wear a high-grade mask when they're around others, both indoors and outdoors, until 10 days have passed from their positive test or the day their symptoms began. Schools can receive a lot of assistance from public health to support case identification, notification, and contact tracing. I want to also thank all the school administrators because all school staff have been issued a surgical masks or N95 or KN95 respirators. Students are also advised to wear upgraded non-cloth masks of multiple layers of non-woven material with a nose wire that fits well. Next slide. Getting tested is not just an important strategy in our schools, but it's an important strategy across our communities for reducing spread, especially for those who have symptoms, were exposed to an infected person, have traveled, or they're gathering with others who may be at high risk. Thanks to massive efforts by the state, the county, especially the Department of Health Services, and the federal government, we are in a better place today than we were just a few weeks ago. This map reflects all community testing sites as of January 8th. Of note, you can kind of see the yellow halo that covers a 10-mile radius around each testing site is a proxy for the state's expectation that at least 75% of a region's population has a testing site within a 30-minute drive in an urban area and a 60-minute drive in a rural area. And you'll see here across the county, we meet and we actually exceed that standard. In total, there are currently more than 189 community testing sites, 21 county-run sites, 7 state-run sites, and 36 pop-up testing sites. We do encourage all LA residents to visit covid19.lacounty.gov/testing if you need information about testing or you need to find a convenient testing location near where you live or work. Next slide. But there's also new opportunities for residents to now receive in-home antigen test kits. The federal government recently announced that every home in the United States is eligible to order 4 free at-home COVID-19 tests. These tests are completely free, and you can order them now at covidtest.gov. Orders typically we should ship in 7 to 12 days, so won't meet an immediate need, but we do urge everybody who has access to the internet to go ahead and sign up so you can get that small supply coming to your home. This is a good strategy to have these test kits in your home so that if you come down with symptoms, it's pretty easy for you to get a quick result as to whether or not you may be infected with COVID. Insurance companies, I want to note, are also now required to reimburse you for 8 tests per month for each individual that's on a plan. And they have to cover up to $12 per individual test. Your health plan can cover the cost of your tests if they have a network of pharmacies or retailers already set up. But alternatively, you can be provided with reimbursement for the cost of over-the-counter tests, regardless of the price, if they don't have a network for you to visit. The best way for you to find out what your health plan or insurer is offering is to go ahead and get in contact with them. But you can also visit covidtest.gov for more information on the reimbursement requirements. This is a federal requirement for health plans and insurers. So you can best understand the opportunity that's here as well. And while again, there are some delays in receiving test kits, right now, if you go online, there are sites where you're able to order test kits that should come to you again within a 2-week period. So good idea for folks to take advantage of these 2 opportunities. These are easiest to do if you have internet access, and please go to our libraries for help with that as well. But also, we are encouraging folks to go ahead and sign up. I'll go on to the next slide. While for many, after testing, fortunately, the result is negative, increasingly during surge, there are lots of people, including those without symptoms and those fully vaccinated, that are testing positive. When you test positive, there are several important steps that we'd like you to take. First, it's important to know that you have to isolate and stay home, and you'll need to figure out that isolation period based on your symptoms and whether or not you have a fever. But as you know, the requirements apply to everyone except healthcare personnel, that if you are infected, you must stay home away from others for at least 5 days. If you want to exit isolation after day 5, you do need that negative COVID-19 test collected on day 5 or later. You also need to have no fever for at least 24 hours without the use of fever-reducing medicines and be asymptomatic or have improving symptoms. If you don't meet these criteria, you'll be able to exit isolation after day 10, provided again you don't have a fever for at least 24 hours without using fever-reducing medicine, and you don't have any symptoms or you've had a significant improvement in your symptoms. We also ask that you please tell all your close contacts that they have been exposed and they now need to follow the instructions for close contacts. And as a reminder, people are close contact if they came within 6 feet of you in the period of time 48 hours before you had a positive test result or developed symptoms. So you've got to look back in time to figure out who your close contacts were. Those were people within 6 feet for 15 minutes, for at least 15 minutes over the course of a day. If you test positive and you have questions or you need help, you can always call the Department of Public Health 7 days a week between 8 a.m. and 8:30 p.m. That number is 833-540-0473. Additionally, as a reminder, you'll need to wear a well-fitting surgical mask or higher grade mask around others, both indoors and outdoors, for that 10-day isolation period. This is particularly important for those that are going to exit isolation after day 5 because you had that negative test result. You need an N95, a KN95, a KF94. These are going to be best when it comes to blocking COVID virus particles. But surgical masks, especially when doubled, also work well. Next slide. In closing, I do want to share preliminary data from USC scientists that powerfully demonstrate the promise and potential of vaccinations to control this pandemic. These scenario estimates are produced from a model based on values that are imperfectly known and have what we call wide confidence intervals, meaning that the certainty among the estimates is not precise. The modeling framework here also makes simplifying assumptions to represent the very complicated dynamics in boosted and vaccinated individuals, vaccinated but not boosted individuals, and unvaccinated individuals within a single population model, despite understanding that there are complex dynamics that are at play within and across each of these groups. Nonetheless, these preliminary estimates show profound impact of vaccinations on the trajectory of COVID across LA County. When looking at cases, estimates from the model predict that if everyone eligible were vaccinated, there would have been 85% fewer cases, or approximately 604,000 cases of COVID-19 prevented between December 1st and January 13th. If everyone eligible were boosted, there would have been 96% fewer cases, approximately 680,000 cases would have been prevented. When looking at hospital admissions, the results are equally substantial. Estimates from the model predict that if everyone eligible was vaccinated, there would have been 87% fewer hospital admissions, again, for the period from December 1st to January 13th. That's approximately 9,300 hospitalizations that would have been prevented. And if everyone eligible were boosted, there would have been 98% fewer hospital admissions, or approximately 10,500 hospitalizations prevented. Even with the limitations of this model, these estimates, which actually align with much of the data we're able to present on vaccine protection for LA County residents, show just how much impact large-scale vaccine adoption at a population level could have on the pandemic's trajectory, our case and hospitalization reductions, and ultimately can help lead to the end of the pandemic. Thank you, and now I'm happy to take your questions. And so is Supervisor Mitchell.
If you have a question for Dr. Ferrer, Supervisor Mitchell, please use the hand icon or you may chat me, the host, directly. Our first question comes from Ryan Carter from LA Daily News. Ryan, go ahead.
Hello, Dr. Ferrer and Supervisor Mitchell. Thank you for the time today. A quick question. I've obviously been hearing about this critical blood shortage happening throughout the country and locally no different. I'm just kind of wondering, Dr. Ferrer, if you've got kind of a reaction to that, some perspective on how that shortage is playing out in the county, and the extent to which people should feel okay about giving blood, even perhaps after they've had COVID themselves. And the second question is really about, and I know we're so mired right now in the thick of the surge right now, but wondering if you're looking to a future where COVID is going to just be around indefinitely, and even from a public policy point of view for Supervisor Mitchell, if it's no longer about really beating the virus as it is more about managing it in the future. Thank you very much.
Yeah, thanks so much, Ryan. I'll start and then I would love to have Supervisor Mitchell really talk about living with COVID, because I think that is our future, living with some variation of COVID, certainly our near future for sure. But let me just start with the blood shortage, because it's such an important issue. So first, I want to reassure everyone, the Red Cross, which manages our blood supply, really goes to extraordinary lengths to protect that blood supply. And so everybody who is trying to figure out are they an appropriate donor should go to the Red Cross website where they'll tell you what the screening requirements are. But I want to note in general, people who have recovered from COVID illness, yes, you in general, depending on other illnesses or exposures you may have had, you're fine to go ahead and give blood. And again, you know, there's an extensive screening process that the Red Cross does to protect our blood supply. So everyone should feel safe about giving blood and safe about getting blood. And the process, you know, now for actually being able to donate is COVID friendly. And by that I mean that they have taken all the protections at the donors at donation sites to make sure that people are fully masked, that people are distanced, that infection control, as always with blood donations, is top on the list of practices that you'll see at all of the blood donation sites. But it is really important that people continue to give blood during the pandemic, because our hospitals actually need those blood supplies to be able to continue to do all of the services that they provide. It's especially important, as everybody knows, for emergency treatment and for surgeries. So I'm going to urge people to go ahead. There was an outpouring of folks once they heard about the blood shortage, the blood supply shortage, to go ahead and start donating again. But I'm going to urge people, go ahead, please find a blood donation site near you. For those of you who have been blood donors for years, thank you so much. This is a life-saving service that you're performing. For everybody who's looking for something good to be able to do, to contribute to efforts to get us through the pandemic, donating blood is something relatively simple that just about everyone can participate in. And I'll turn it over to Supervisor Mitchell about sort of managing with COVID.
I appreciate the question. And as I've, heard Dr. Ferrer say, really through our Omicron experience, that we were transitioning to a how to manage it better kind of way of thinking. And so as a policymaker, as a leader here in the county, when I think about county's responsibility around people we house, primarily people we house in congregate settings, from our jails to our juvenile detention facilities, to skilled nursing facilities, to shelters, rethinking how we build and manage congregate living settings. I think on an ongoing basis, we have to be mindful of that in terms of, new construction, how we build spaces where folks can isolate, we can keep people further apart. I think, personal habits and accountability are going to have to change. I've thought often of my own experience traveling in various Asian countries, China, Japan, South Korea, and seeing the normalcy around mask wearing when you're sick in public and in public transit, and wondering if that will become normal for our country minimally, that we begin to take personal responsibility. If you're sick, that you wear a mask, as many nations that are densely populated have done for many, many years. And so I think those are personal habits and responsibilities, as well as what government is going to have to do to respond to this on an ongoing basis, much like we step up during cold and flu season and make, en masse flu shots available to folks. That may be the same with COVID if there are additional boosters going into the future. But I think the way in which we house people, the way in which we fund public health, the way in which all of us on an individual basis alter our own personal practices and hygiene and lifestyle is going to have to, on a go-forward basis, be based on the reality of our last 2 years. And if I can just add more piece, the USC study, your final slide, Dr. Ferrer, was very striking. And I have to say, when I looked at the hospitalization rates, I not only thought about the human cost, because what that slide didn't take it to the next level to talk about how many lives could have potentially been saved, but, as someone who has a level of fiduciary responsibility with regard to the county budget, it also makes me think about actual fiscal costs to our overall healthcare and delivery infrastructure. So much of that could have been avoided if we were able to convince more people to get vaccinated and boosted.
Thank you, Supervisor. I think we can go on to the next question.
Our next question comes from Ron Lynn from the LA Times. Ron, go ahead.
Hi, Supervisor and Dr. Ferrer. Thanks so much for taking our questions. We really appreciate it. Dr. Ferrer, our question today about our crystal ball question, the advice on non-essential gatherings and Lunar New Year, and finally a question about Omicron severity. So first, San Francisco has said they think they're on the downslope. Do you think we're plateauing, or do you think we're on the downslope? And what's your best guess for when cases might start to get to like early December levels and when hospitals might just start to see relief? Second, you've urged that people postpone non-essential gatherings, and some people have held back on things like indoor dining and indoor gyms. When do you think those activities can resume? And do you think there's more leeway around multi-generational family dinners around the Lunar New Year on February 1st? Or does your past advice still remain the same given the high case rates? And then finally, there's been a lot of talk about Omicron being less severe, yet your numbers have shown a doubling in the death rate in recent weeks, and children's hospitals in LA and Orange County are reporting pandemic high numbers of coronavirus hospitalizations among children at their facilities. So how do we sort through this seemingly contradictory idea, this idea of a less severe Omicron, but a rapidly rising death rate? Thank you.
Yeah, thanks so much, Rhonda. Let me start at the bottom because this is an issue that I think is of paramount importance. I too have heard from so many people like, oh, Omicron's so mild, no need to worry. I'm not really gonna take a lot of precautions. Everyone's gonna get Omicron, and let's just get it over with. And I am firmly in the camp that is an inappropriate response to where we are at this point in the pandemic. And I say that because of the data. There are still many, many people whose lives are completely unended by this virus. And we don't have enough information on Omicron to best understand long COVID and its relationship to this strain of the virus. We don't have really hardly any information on MIS-C for pediatric cases. That is where people had very mild illness. Children had very mild illness, and then weeks later developed life-threatening illness associated with infection from COVID. So I don't think anybody should be rushing out to get COVID. I think when you have a vaccine-preventable disease, that is not a sound strategy. That's why we have vaccines, to provide a level of protection that in this case looks like it is better than the natural protection people are getting if they get infected. And it's certainly as good as people who got infected with Delta, it turns out, have high reinfection rates with Omicron. So, I want to just note, getting infected for many people is not so easy. And when we talk about mild and moderate illness, you could talk to people who are up 3-4 nights in a row. Yeah, they're home, they're not in the hospital, but they can't sleep because they're coughing, or they've lost their sense of taste and smell for weeks, or they have had a fever, or they're isolating from the people they love for a long period of time and missing birthday celebrations. So yes, I think everyone needs to continue to be cautious. So I'll sort of segue into the question about what should we all be doing? We need to be extraordinarily cautious when there's this much community transmission. We've actually never had this much community transmission at any other point during the pandemic. And what I mean by that is it's extraordinarily easy to be exposed. And for some people, when they are exposed, they can go ahead and become infected. And a small number of those people are in our hospital right now fighting for their lives. So yes, I still think it makes a lot of sense to evaluate your own risk, the risk of those people you love, and then make decisions about which of the higher risk activities you're going to participate in. For some people, the higher risk activity is that they have to go to work every day, and their work entails being around lots and lots of people. So they're going to have a lot of potential exposures. And they may say, because of that, because of the importance of my work, I'm going to be super careful everywhere else. And I'm going to really avoid, this isn't for a long period of time. This is to get us through surge. I'm going to avoid going to an indoor restaurant, or I'm going to avoid in particular going out at night to an indoor bar, because those are places where exposure rates can be extraordinarily high as people are unmasked and indoors. In terms of your family dinners, I don't think I'm changing the guidance. Everything is better outdoors. If you have members in your family who are at very high risk, this would be the time to probably do a delay. Unless you can get everyone tested right before you gather. So again, having people test negative, having people distance, having people outside, being careful to mask up when you're not eating or drinking, using a high quality mask, all that makes a difference. But for some people, this time for them is just very risky. And that includes people who are unvaccinated, particularly if they're older, particularly if they have underlying health conditions, or they're immunocompromised. So again, I don't think our advice is really changing. I think we acknowledge that all of us have to do that assessment with any non-essential activities that we're doing about whether this is, kind of where I'm going to be willing to take on some risk, or this is an activity that I think I can just delay for a little bit because it's not worth the risk I may be taking on. In terms of where we are, I'm really hopeful that we're plateauing. I need to look, because we had a holiday weekend. I need to look at the data from tomorrow and Saturday to be sure. But I also track on episode dates, and it looks like around January 8th, January 9th is when we had our highest really daily case rates, when we go back and figure out at what point did someone either test or have symptoms. And that would be encouraging for us because that would mean that we really are in a plateau right now. I'd love to see signs that we're in a real decline, but I think we have to wait to get a complete week's worth of data here. We do have some other signs that point to the possibility of less virus circulating. I mean, obviously, test positivity has dropped a little bit, not a lot, but a little bit. Some of the wastewater analysis that's done for LA County, for certain regions of LA County, particularly, I think the downtown West LA area, the wastewater analysis shows lower levels, slightly lower levels of the virus. In other parts, east, and this really maps to what we're seeing on our cases. The eastern part of LA County, the southern part of LA County continue to still have a pretty high level of virus in those wastewater samples. So again, I don't think we're yet on the downslope. I'm hopeful that we're plateauing, but we'll know more by the weekend as we follow the data for the rest of this week. With that, I think we can go to the next question.
Next question comes from Sarah Donchi. My apologies on the pronunciation. From CBS. Sarah, you're unmuted. Go ahead.
Thank you, ladies, for your time. We always appreciate you and the hard work you're doing. My question is kind of circling back to the living with COVID idea and the USC study, the results that came out of it, and the conclusions that were made by some of the folks who worked on that, including the director of the COVID initiative at USC, who said that he believes that we should pivot our pandemic response from minimizing infections to minimizing the harm from infections. I realize it's difficult to predict the future. You both don't like doing that, and I understand why. And it's hard to talk about this given the fact that we are in this historic surge. But I want to know, I mean, all of the messaging and the policy right now still seems to be focused on preventing infections. What will it take for the messaging and the policy to catch up with the idea that, yes, we will have to live with COVID, given the fact that it's possible that a new variant, may spring up, until we don't know when? I mean, what in your opinion, Dr. Ferrer, what will things need to look like in our community for us to sort of shift to that stage of things in messaging and in policy? Thank you.
Yeah, thanks, Sarah. I mean, that's a really important question. I would say that it might not be, sort of an either or, because, definitely the rate of infections has something to do with the harm that gets caused. But I do think there are two areas where we need to strengthen our response. The first is on the therapeutic side. If you've got really great therapeutics with no scarcity around the distribution of those therapeutics, minimizing harm is a lot easier to do. And we're just starting to see the distribution of the oral antivirals, one of which is highly effective, but of super limited supply. So you can't really have scarcity in your therapeutics and talk about minimizing harm. You've got to actually be able to do a really, really good job making sure that those effective therapeutics are going to be widely available, particularly to people who are of limited economic means, may not have good health insurance, may live far from healthcare hubs, and may not have a primary care physician or clinic in that they easily access. So I want to really emphasize, to get to the minimizing the harm side of the equation, we've got to have better therapeutics. We also have to make sure that we don't continue to have problems with access to testing, because testing is one way to then, I think, be much more effective on both minimizing spread and minimizing harm, because you really have a way of knowing your status before you engage in some activities where you could inadvertently be transmitting to others for whom the consequences could be very serious. I think the third area that we are going to need to address, to really be able to minimize the harm, is to take a hard look at the staffing shortages that we're now experiencing across the entire healthcare system. Because again, one of the strategies on minimizing harm is to protect the healthcare system. But as you can see, even with lower numbers of people in the hospitals this go round, this surge compared to the winter surge, our hospitals are overtaxed and under enormous strain. So we're going to have to deal with the staffing issues, and some of those are complex issues, not quickly resolved, but need a lot of attention. Some have to do with pay and pay equity. Some of those have to do with making sure, again, that we've got adequate protection built in at all of these workplaces. And some of it has to do with recognizing the enormous burnout and strain on healthcare professionals and trying to figure out, how to, be able to manage during these long-term events with, being able to allow people to go on vacations, to not be working overtime, a week in and week out. So I think you're right that there's an opportunity to really focus on minimizing harm. I'm not sure it's instead of, but I do think we would need to address those three areas in order to really be successful in that approach in this country. I don't know, Supervisor Mitchell, I'm sure you might want to add as
I
well.
just have a fourth to add, if I may, from a layperson's perspective. And when I think about minimizing harm, vaccinations minimize harm and spread and severity. And so as we talk about, as you mentioned, our challenge around equitable access to all healthcare services, I think we have done a better job, because we've been at it longer, around equitable access to vaccines. So I don't want the notion of getting more people vaccinated to be lost from this notion of minimizing harm.
Yeah. Absolutely correct. Should have been number one. So thank you, Supervisor. We have time for just one more question. I'm sorry. And you can always send in your questions if we didn't get to them, and we'll get back to you.
Our final question comes from David Singer from KNX. David, you're unmuted. Go ahead. Oh, I apologize. He doesn't have a microphone. David's question is, deaths are a lagging indicator and they topped 100 today. How long do you expect the death numbers to remain so high before likely infections start to decline?
Yeah, it's a great question. Thanks, David, for asking it. I mean, it's a great question because one of the areas our team is doing a deeper dive in is it looks to us like folks may be progressing faster who are infected with Omicron from the time that they are diagnosed as being infected or they started having symptoms. We call that the episode date to the date of death. So we're seeing a much shorter time frame, and that's tragic. It means that for the people who are in fact ending up passing away from COVID, if they were infected with Omicron, it looks like they get hit pretty hard earlier on. And we don't have, in the past, particularly with Delta, we had people who, their episode date may have been, a month, 5 weeks before they passed away. But in this latest set of numbers that we talked about today with the over 100, I think it's 102 people that passed away, looking preliminarily at the data, I want to say that 80% of the infections were post January 1st. 90% were post December 25th. But that's a relatively short period of time between the time somebody gets infected, gets their symptoms, and then passes away. So we may have to get more information on what that really looks like for people who are infected with Omicron before we can feel confident that we can estimate when we might see deaths stabilize and then again start declining. In the past, it's been weeks. I mean, you all know because we all lived through winter surge together, and it took weeks after cases declined for deaths to go back down. But if deaths are going up quicker and there's less of a lag between cases and deaths, then you might also see less of a lag on the other end as well. But we'll keep you posted on that. In the past, it's been weeks. I think it was more than 5 weeks last time before deaths actually dropped to a relatively low level. So with that, thanks a lot, everybody. Supervisor, I'll let you close us out. I think you're muted.
Dr. Ferrer, in your slides, could you share the websites where people can find testing sites and how they can report if they are at a testing site that's suspicious? I just think that's important to share.
Yeah, I mean, I shared the email address that you can go to find a testing location near you. It's covid19.lacounty.gov/testing. That also is a place you can go to get any kind of information you want on testing as well. For reporting, if you're concerned fraudulent testing, you've been ripped off. There are some new numbers. I don't have them on the top of my head, but they are prominently on our website. And I think they're also on the testing website about where you can report, because there's both state reporting you can do, there's local reporting, and there's federal reporting that you can do as well. So, and we appreciate folks always letting us know where there's a problem so we can investigate and get that information out quickly. In many cases with testing sites, if they're really not appropriately set up, then they do get shut down. So that's one good thing about the testing sites is people are not allowed to continue with an operation that's not safe.
I agree. I think that's the important last word. I'm glad to hear there's a phone number, because the website I have for for reporting a website is not the most user-friendly website, I might add, which is dcba.lacounty.gov/newsroom/avoid-COVID-19-testing-fraud. That's not an easy one to plug in. So I'm glad to know that there's a phone number where people can report and it can be found. I think it's important for our media partners to share that information broadly, because people seem to want to know those two points of information.
I mean, I'll also give you our complaint line. These are complaints for any work site. So any work site related complaint issues, but this, testing sites are work sites as well. So feel free, if you can't, if you don't find another way, you can report to us 888-700 9995. So we deal with all kinds of workplace complaints. These are anonymous. You can report anonymously. So if you're working at a testing site and you think it's not exactly set up appropriately, or you go to a testing site and you don't think it's appropriate, and you can't easily find one of the state and federal government sites to report into, or you don't have access to the internet, please go ahead and give us a call and we'll make sure it gets to the right people. So, thank you, everyone. We'll talk to you next week. Thank you,
Thank you.
Supervisor.
Thank you, Dr. Ferrer.
Thank you for attending today. Any additional questions that we did not get to today, you may send to our media inbox at media@ph.lacounty.gov. Our Spanish remarks will begin in just a few minutes. Thank you. Hey, Monica, can you hear me?
Yes, I can hear you.
Great, I have your slides ready to go. So welcome everybody for the Spanish portion of today's briefing. Today is January 20th. We have Monica presenting.
Okay, thank you so much, Kim. Muy buenas tardes. En esta sesión, primero proporcionaremos una actualización sobre nuestros casos, hospitalizaciones y muertes actuales, seguido de los datos de vacunación más recientes y el manejo del aumento repentino en nuestras escuelas del Condado de Los Ángeles. Y terminaremos con una revisión de los recursos de acceso a la prueba, los pasos a seguir después de dar positivo, por qué las vacunas pueden marcar la diferencia y cuál es la mejor manera de protegernos a nosotros mismos y a nuestros seres queridos si hemos dado positivo durante este pico de la pandemia. First slide, please. Bueno, como puede ver en esta diapositiva, el promedio de nuevos casos sigue siendo extraordinariamente muy alto. Hay pequeñas disminuciones con respecto a la semana pasada. El promedio diario de nuevos casos es de aproximadamente 33,000 casos y la tasa de casos positivos descendió levemente la semana pasada a aproximadamente 17%, lo que significa que cada 6 personas que se hacen la prueba resultan infectadas con COVID. Nuestra tasa de casos promedio diario por 7 días también ha mermado un poco a cerca de 350 nuevos casos, a cerca de por 100,000 habitantes. Y aunque esto puede significar que ya no estamos viendo un crecimiento exponencial del contagio, estamos experimentando la tasa más alta de propagación de esta pandemia. Y con tantos casos, nuestras cifras de hospitalizaciones siguen siendo altas, con 4,814 personas actualmente hospitalizadas, el mayor número de hospitalizaciones diarias por COVID desde el aumento del invierno pasado. Y como hemos visto en el pasado, unas pocas semanas después de un aumento en los casos, por desgracia, las muertes también se incrementan. Hoy nos entristece informar 102 muertes por COVID-19, la mayor cantidad de muertes diarias que hemos informado desde marzo 10 del año pasado. La cantidad de nuevas muertes se ha duplicado en la última semana y el 90% de las muertes reportadas hoy se encuentran entre personas que se enfermaron con COVID después del 24 de diciembre, lo que indica la alta probabilidad de Omicron ha sido la causante de la infección. Para todos los que están devastados por la pérdida de un ser querido debido a COVID, sepan que nos sumamos a muchos otros para enviar pensamientos y oraciones por consuelo y paz. Los casos positivos con base en la prueba siguen siendo muy altos, aproximadamente el 17%, lo que significa que casi una de cada 6 personas que se hacen la prueba está infectada con COVID. Nuestras tasas de casos diarios, promedio de 7 días, también se han mantenido elevadas en alrededor de 350 a 400 casos por cada 100,000 residentes. Next slide, please. Esta diapositiva muestra nuevos casos, hospitalizaciones y muertes entre el 1 de julio del año pasado y la actualidad. El aumento de casos representado por la línea verde en la parte superior es casi una línea vertical recta casi una línea vertical recta hasta hace poco. Esta caída para el promedio diario de casos nuevos por 7 días observada recientemente puede indicar el comienzo de una disminución, pero también refleja retrasos en la notificación de casos del fin de semana festivo. Como pueden ver en la línea de tendencia de casos, ha habido un aumento de 3,000% en los casos desde principios de diciembre, con 1,000 casos nuevos diarios, a aproximadamente 36,000 casos nuevos diarios esta semana. Del mismo modo, los ingresos hospitalarios en la línea naranja aumentaron casi 1,000% desde principios de diciembre, de menos de 60 nuevos ingresos diarios a más de 600 nuevos ingresos diarios. Con el aumento más reciente de muertes durante la última semana, lamentablemente ahora vemos que la línea azul también sube. Mirando más de cerca las hospitalizaciones, excuse me, next slide, please. Mirando más de cerca las hospitalizaciones, observamos en esta diapositiva que el rápido aumento de las hospitalizaciones por COVID en las últimas semanas, la línea naranja, ahora también se correlaciona con un aumento en el censo diario de hospitalizaciones. Con un censo diario de más de 15,000 pacientes hospitalizados, las clínicas están cerca a alcanzar el censo total de 16,500 pacientes experimentado durante el pico. A medida que observamos las hospitalizaciones, es importante tener en cuenta que nuestro modelo actual estima que el porcentaje de hospitalizaciones debido a la enfermedad de COVID es aproximadamente el 50% de los pacientes positivos para COVID. Esto significa que el 50% de pacientes actualmente hospitalizados con COVID positivo en realidad están en el hospital por una enfermedad que no es de COVID. No obstante, independiente del motivo de su hospitalización, todos los pacientes con resultado positivo de COVID aún requieren precauciones que consumen muchos recursos y ejercen una presión adicional sobre nuestro sistema de atención médica, particularmente en el contexto actual de escasez de personal. Next slide, please. Los pacientes con COVID, como puede ver en esta diapositiva, representan el 30% de los que están en urgencias, lo que representa un aumento del 25% de los pacientes que han sido admitidos en urgencia con respecto a lo que observamos la semana pasada. Entre los aumentos de muertes y hospitalizaciones, no debe haber lugar para sentirnos muy confiados. Si bien Omicron no está causando la misma proporción de enfermedades graves que vimos el invierno pasado, el número de casos de enfermedades está aumentando sustancialmente en el condado de Los Ángeles. Omicron se ha convertido en la variante crítica de vida o muerte. Next slide, please. Como siempre, rastreamos los datos más recientes sobre las variantes secuenciadas aquí en el condado de Los Ángeles. La barra roja representa Omicron y la barra azul representa Delta. Como puede ver, similar a los patrones que se observan en todo el país, Omicron, que se muestran en las barras rojas, representa el 99% de los especímenes secuenciados la semana que terminó el 8 de enero. Next slide, please. A medida que Omicron ha pasado rápidamente a dominar, el número de casos ha aumentado en todas las comunidades del condado de Los Ángeles, como puede ver aquí. El color verde más oscuro en cada mapa representa el 20% de las comunidades con las tasas de casos más altas de COVID. Estos mapas fueron secuenciados a principios de diciembre de principios de diciembre a principios de enero. En los primeros días de diciembre y al comienzo de la propagación de Omicron, los que tenían más probabilidades de infectarse eran los viajeros, quienes asistían a lugares de entretenimiento y los que se mezclaban en sitios donde había muchas personas juntas sin mascarilla. Algunos de los cambios recientes asociados con la propagación comunitaria generalizada probablemente reflejen un mayor contagio entre aquellos cuyos trabajos los ponen en contacto cercano con otros, ya que a menudo viven en casas muy llenas. Next slide, please. Durante la pandemia hemos sido testigos de que los residentes afroamericanos y latinos han experimentado los peores resultados por enfermedades causadas por COVID. Y cuando observamos la oleada más reciente, vemos un patrón similar. Este gráfico muestra las tasas de casos por raza y etnia desde junio del 2020 al 8 de enero de este año. Si bien está claro que todas las razas y etnias experimentaron aumentos significativos en las tasas de casos debido a Omicron, que representan a todos los grupos en el periodo más reciente con las líneas casi verticales al lado derecho, observamos las tasas de casos más altas en la población latina, representada por la línea amarilla, con aproximadamente 3.600 casos por 100.000 habitantes, un aumento de 1.900% en comparación con el mes anterior. Los afroamericanos, representados por la línea verde, tienen la segunda tasa de casos más alta, con casi 2.700 casos por 100.000, un aumento de 1.400% en un mes. La población asiática, representada por la línea azul, ha visto el aumento porcentual más pronunciado, con un incremento de 2.400%, es decir, 2.300 casos por 100.000, seguida de los residentes blancos en la línea morada, con un aumento de 1.100% y 2.100 casos por 100.000. En general, Como lamentablemente hemos visto durante aumentos repentinos anteriores, nuestros residentes latinos y afroamericanos continúan experimentando de manera desproporcionada la carga de casos que se observa actualmente durante el aumento repentino de Omicron. Next slide, please. Cuando observamos las tasas de hospitalización por raza y etnia, vemos un patrón similar, ya que todos los grupos han experimentado aumentos significativos. Sin embargo, como hemos visto durante todos los aumentos repentinos anteriores, las poblaciones afroamericanas y latinas son hospitalizadas a tasas desproporcionadamente más altas que las de los residentes blancos y asiáticos. Durante el periodo de 2 semanas, al 8 de enero, la tasa de hospitalización de afroamericanos fue de 47 por cada 100,000 personas. La de los latinos fue de 29 por 100,000. La de los blancos, 17 por 100,000 y la de los asiáticos, 8 por 100,000. La brecha entre los residentes afroamericanos y los residentes asiáticos es casi 6 veces mayor. Next slide, please. Al comparar las tasas de mortalidad entre razas y etnias, parece que las líneas pueden estar muy juntas al lado derecho. Sin embargo, al ver más de cerca los datos, vemos que ya se están abriendo brechas aquí también. La tasa de muertes actualmente para los residentes afroamericanos es de 3,5 muertes por cada 100,000. La de los residentes latinos es un poco más de 3 muertes por cada 100,000 residentes. Esto se compara con los números bajos de muertes de los residentes blancos, de 2,5 muertes por cada 100,000 personas, en comparación con los asiáticos, de una muerte por cada 100,000 personas. Dado que las muertes suelen retrasarse varias semanas con respecto a las hospitalizaciones, por lo que lamentablemente es posible que veamos en las próximas semanas aumentos en todos los grupos raciales y étnicos y también un gran incremento de estas brechas. Next slide, please. Cuando examinamos las tasas por raza, origen étnico y estado de vacunación de las hospitalizaciones durante un periodo de 2 semanas al 8 de enero, está claro que en todos los grupos por raza y etnia, los no vacunados son hospitalizados con tasas sustancialmente más altas en comparación con los vacunados. Claramente, la vacuna brinda una protección sustancial a todos los vacunados. No obstante, es importante tener en cuenta que las tasas de hospitalización para las poblaciones afroamericanas y latinas son sustancialmente más altas en comparación con el estado de vacunación de las personas blancas no hispanas y las asiáticas. Por ejemplo, las personas latinas no vacunadas tienen una tasa de hospitalización 3 veces mayor en comparación con las personas asiáticas no vacunadas. Y también las personas latinas vacunadas tienen una tasa de hospitalización 3 veces mayor en comparación con las personas asiáticas vacunadas. Estas diferencias pueden reflejar las tasas más altas de enfermedades subyacentes, condiciones de salud entre los residentes afroamericanos y de color debido al acceso inadecuado a los recursos de salud. Next slide, please. Las vacunas, como acabamos de ver, brindan una protección poderosa contra los peores resultados de COVID. Eso fue cierto el pasado enero cuando pudimos vacunarnos por primera vez y sigue siendo cierto hoy. Durante el año pasado, más del 77% de los residentes mayores de 12 años se vacunaron por completo, junto con casi el 90% de los residentes mayores de 65 años, y eso representa un progreso. Sin embargo, el número de niños de 5 a 11 años con al menos una dosis es solo del 29%. Esto está muy por debajo de todos los demás grupos de edad aprobados en todo el condado de Los Ángeles y crea el terreno fértil para una propagación significativa. Y si bien seguimos agradecidos por los casi 3 millones de residentes del condado de Los Ángeles que ya recibieron su dosis de refuerzo, hay otros 3 millones de residentes mayores de 12 años que han sido aprobados para recibir el refuerzo y que aún no han tomado su dosis adicional. Dado que los datos continúan mostrando que nuestro sistema inmunológico necesita ser reforzado, instamos a aquellos aprobados a sacar el tiempo para obtener su capa adicional de protección. Next slide, please. En este gráfico seguimos rastreando nuestro progreso en la administración de vacunas. Las primeras dosis administradas cada semana están representadas en azul, mientras que las segundas dosis están en amarillo y las dosis adicionales o de refuerzo están en naranja. La semana pasada administramos aproximadamente 260,000 dosis, una disminución con respecto a la semana anterior de aproximadamente 50,000 dosis. La mayoría de estas dosis, 180,000, fueron refuerzos, 50,000 fueron primeras dosis y 34,000 fueron segundas dosis. Next slide, please. Y desafortunadamente, después de un año de campañas de vacunación y asegurarnos de que todos tengan fácil acceso a vacunas gratuitas, existen enormes brechas de cobertura por grupos de edad, raza y etnia, como se ve en esta tabla. Lo más preocupante son los números de cobertura general para los niños de 5 a 11 años y que solo 1 de cada 6 niños afroamericanos y latinos de 5 a 11 años estén vacunados. Con millones de niños en todo el país ahora vacunados y las altas tasas dominantes de casos de Omicron entre los niños, tenemos la esperanza de que los padres se sientan más seguros de la necesidad de vacunar a los pequeños y más confiados en la efectividad y seguridad de estas vacunas para niños. Y aunque algunas brechas entre adolescentes y adultos se han cerrado ligeramente, aún debemos continuar con todos los esfuerzos para garantizar que aquellos que aún no están vacunados tengan fácil acceso a buena información y a las vacunas. Next slide, please. Continúan los esfuerzos de los administradores, el personal, los padres y los estudiantes para garantizar la seguridad en nuestras escuelas. Una estrategia importante para minimizar las exposiciones, especialmente durante este pico, es que las personas se hagan la prueba. Esta diapositiva muestra el volumen de pruebas administradas en las escuelas, representado por las barras azules, y los casos positivos detectados con las pruebas representados por la línea de tendencia morada desde el agosto pasado. Vale la pena aclarar que la caída en el volumen de pruebas a fines de noviembre y diciembre se debió a las vacaciones. Más recientemente se administraron casi 595 pruebas a estudiantes y personal en escuelas de kinder a grado 12 entre el 10 y el 14 de enero de este año. Entre las pruebas administradas, el 11% fueron positivas. Esto es una disminución del 15% con respecto a la semana anterior. Tenemos la esperanza de que los casos positivos con base en las pruebas continúen disminuyendo a medida que los estudiantes y el personal infectados asintomáticos se identifiquen temprano y sea menos probable que expongan a muchos otros en las escuelas. Next slide, please. En la siguiente diapositiva mostramos los casos entre el personal y los estudiantes de transición a grado 12 desde agosto del 2021 al 16 de enero de este año. La semana pasada hubo 4,430 casos de estudiantes que se ven en la línea azul, que experimentó un aumento del 55% con respecto a la semana anterior. Mientras tanto, para los casos del personal, observamos 364 casos con la línea morada que experimentaron una disminución de 59% con respecto a la semana anterior. Tenga en cuenta que este gráfico solo incluye casos que estuvieron en los planteles dentro de los 14 días posteriores a recibir el resultado positivo de la prueba. La mayoría de los casos identificados en las escuelas han sido de contagios adquiridos en la comunidad, dado que Omicron se ha extendido bastante en nuestros vecindarios y que solo se han identificado hasta ahora unos pocos brotes en las escuelas, como veremos a continuación. Next slide, please. A partir del 18 de enero, Salud Pública ha respondido a 24 brotes escolares activos con 3 nuevas investigaciones de brotes abiertas la semana pasada. La transmisión en las escuelas se caracteriza como un brote cuando hay 3 o más casos vinculados a una exposición conocida en la escuela o en una actividad escolar. De los 3 nuevos brotes, dos fueron en escuelas primarias y 1 en escuelas secundarias. Dadas las altas tasas continuas de transmisión comunitaria y el aumento significativo de casos entre los estudiantes, anticipamos que durante el aumento también puede haber más brotes en las escuelas. Esto es similar a los aumentos dramáticos en los brotes que estamos viendo en otros sectores laborales. Como siempre, limitar la propagación durante los brotes depende de una variedad de estrategias. Next slide, please. Para ayudar a garantizar la seguridad en las escuelas, más de 140 clínicas de vacunas en las escuelas están programadas esta semana y casi 500 puestos de vacunación en las escuelas están programados para febrero. Las clínicas escolares de vacunas ofrecen dosis pediátricas para niños de 5 a 11 años, así como refuerzos para estudiantes que estén aprobados de 12 años y mayores. Las escuelas también están trabajando con Salud Pública y la Oficina de Educación del Condado de Los Ángeles para aumentar la capacidad para aumentar la capacidad de evaluación para manejar mejor las posibles exposiciones escolares mientras apoyan el aprendizaje en persona para tantos estudiantes como sea posible. Ya se han entregado 1,4 millones de pruebas a las escuelas del estado a través de Salud Pública y brindamos apoyo de prueba adicional para nuestras escuelas personal y estudiantes. Cabe destacar que todos los estudiantes y el personal infectados deben aislarse en casa, lejos de los demás, durante un mínimo de 5 días. Los estudiantes y el personal asintomáticos que den negativos en el día 5 de su periodo de aislamiento pueden regresar a la escuela el día 6 o después de su periodo de aislamiento. Los estudiantes y el personal que regresan deben permanecer asintomáticos y siempre usar mascarilla de alto grado cuando estén cerca de otros, tanto en interiores como en exteriores, al aire libre, hasta que hayan pasado 10 días desde su prueba positiva o el día que comenzaron sus síntomas. Las escuelas pueden recibir asistencia de salud pública para apoyar la identificación de casos, la notificación y el rastreo de contactos. Todo el personal de la escuela también ha recibido mascarillas de grado médico, como mascarillas quirúrgicas y respiradores N95, KN95. También se recomienda a los estudiantes que usen mascarilla mejorada o una mejor mascarilla que no sea de tela de varias capas de material no tejido, con un alambre nasal que se ajuste muy bien sobre la nariz. Next slide, please. Hacerse la prueba es una estrategia importante para reducir la propagación, especialmente aquellos que tienen síntomas, estuvieron expuestos a una persona infectada, han viajado y se reúnen con otras personas de alto riesgo. Gracias a los esfuerzos masivos del Estado, el condado, en especial del Departamento de Servicios de Salud y el gobierno federal, estamos mejor hoy que hace unas semanas. Este mapa refleja todos los sitios de prueba que sirven a las comunidades desde el 8 de enero. Cabe destacar que el halo amarillo que cubre el radio de 10 millas alrededor de cada sitio de prueba es un indicador de la expectativa del Estado de que al menos el 75% de la población de una región tenga un sitio para hacerse la prueba dentro de un recorrido de 30 minutos en áreas urbanas y un recorrido de 60 minutos en las zonas rurales en vehículo. En total, actualmente hay más de 189 sitios comunitarios que administran la prueba, 21 sitios manejados por el condado y 7 sitios liderados por el estado y además 36 sitios de prueba en toldos. Alentamos a todos los residentes de Los Ángeles a visitar la siguiente página de internet: covid19.lacounty.gov/testing si necesita encontrar un lugar de prueba conveniente cerca a usted. Next slide, please. También hay muchas oportunidades para que los residentes reciban en el hogar juegos de prueba de antígenos. El gobierno federal anunció recientemente que cada hogar en los Estados Unidos puede solicitar 4 pruebas de COVID-19 caseras gratuitas. Generalmente las pruebas son, por lo general no, continuamente las pruebas son gratis y ahora se pueden pedir en la siguiente página de internet, covidtest.gov. Los pedidos generalmente se envían entre 7 y 12 días. Ahora también se requiere que las compañías de seguros le reembolsen 8 pruebas por mes a cada individuo que tenga plan de salud por un monto máximo de $12 por cada prueba. Su plan de salud puede cubrir el costo de su prueba si ya tienen establecidas una red de farmacias o tiendas minoristas. Como alternativa, pueden reintegrarle el costo de las pruebas de venta libre, independiente del precio, si la compañía de seguro médico aún no ha establecido una red de farmacias o minoristas. La mejor manera de averiguarlo es comunicarse con su plan de salud o aseguradora para determinar si cubren estas pruebas o si es posible que usted solicite que le devuelvan el dinero. Los residentes pueden visitar nuevamente esta página de internet que les voy a mencionar, covidtest.gov, para obtener más información sobre los reembolsos. Next slide, please. Si bien para muchos después de la prueba el resultado es negativo, cada vez más durante este pico de la pandemia, muchos, incluidos quienes no tienen síntomas y los individuos completamente vacunados, están recibiendo resultado positivo. Cuando esto sucede, hay varios pasos importantes que debe tomar. Primero, es importante determinar su periodo de aislamiento y quedarse en casa. Como muchos saben, recientemente actualizamos y modificamos los requisitos de aislamiento para personas en el condado de Los Ángeles con COVID-19. Estos requisitos están alineados con el estado y se aplican a todos excepto al personal de atención médica. Todas las personas infectadas con COVID deben permanecer en casa lejos de los demás durante al menos 5 días. Para salir del aislamiento después del día 5 necesitarán una prueba viral COVID-19 negativa obtenida el día 5 o después. Tampoco debe tener fiebre durante al menos 24 horas sin el uso de medicamentos para reducirla y están asintomáticos o los síntomas mejoran. Si no cumple con estos criterios, puede salir del aislamiento después del día 10, siempre que no tenga fiebre durante al menos 24 horas, sin el uso de medicamentos para reducir la fiebre y esté asintomático o los síntomas mejoren. También pedimos que informe a sus contactos cercanos que han estado expuestos y deben seguir las instrucciones para contactos cercanos. Si da positivo y tiene preguntas o necesita ayuda, siempre puede llamar al Departamento de Salud Pública los 7 días de la semana entre las 8 de la mañana y las 8:30 de la noche al siguiente número telefónico, 833-540-0473. Además, también debe usar mascarilla de grado médico que le quede bien cuando esté alrededor de otras personas, tanto en interiores como al aire libre durante los 10 días. Esto es particularmente importante para aquellos que salen del aislamiento después del día 5. Las mascarillas N95, KN95 y KF94 son mejores cuando se trata de bloquear las partículas del virus de COVID, pero las mascarillas médicas o quirúrgicas también funcionan bien. Next slide, please. Para terminar, nos gustaría compartir datos preliminares de científicos de la USC que demuestran claramente la promesa y el potencial de la vacuna para controlar esta pandemia. Estas estimaciones se hicieron a partir de un modelo basado en valores que son imperfectamente conocidos y tienen amplios intervalos de confianza, lo que significa que la certeza entre las estimaciones no es precisa. El marco del modelo aquí también hace suposiciones simplificadas para representar la dinámica muy complicada en poblaciones con el refuerzo vacunadas, pero sin el refuerzo y no vacunadas dentro de un solo modelo de población, a pesar de dinámicas más complejas en juego dentro y entre cada uno de estos grupos. No obstante, estas estimaciones preliminares muestran el profundo impacto de las vacunas en la trayectoria de COVID en todo el condado de Los Ángeles. Al observar los casos, las estimaciones del modelo predicen que si todas las personas aprobados para recibir la vacuna se inocularan, se habrían evitado un 85% menos de casos y aproximadamente 604 casos de COVID-19. Si todos los autorizados para recibir la vacuna, el refuerzo, perdón, lo hubieran recibido, habría habido un 96% menos de casos, aproximadamente 680,000 casos prevenidos. Al observar las admisiones hospitalarias, los resultados son igualmente sustanciales. Las estimaciones del modelo predicen que si todos los aprobados hubieran sido vacunados, habría habido un 87% menos de ingresos a las clínicas o una prevención aproximadamente de 9,300 hospitalizaciones, y si todos los autorizados hubieran recibido el refuerzo, habría habido un 98 menos de ingresos hospitalarios, es decir, se habrán prevenido una cantidad aproximada de 10,500 hospitalizaciones. Incluso con las limitaciones del modelo, estas estimaciones que se alinean con gran parte de los datos que podemos presentar sobre la protección de las vacunas muestran el gran impacto que la administración a gran escala de las vacunas podría tener en la población durante la trayectoria de la pandemia, la reducción de casos y hospitalizaciones y, en última instancia, el fin de la pandemia. Muchas gracias y hasta la próxima semana.
Thank you so much for everyone who joined us today. As always, if you have questions, you can send them to our media inbox at media@ph.lacounty.gov. We'll see you next week.